Well, my name's Brad Keckner. I'm going to be giving you a brief lecture today on communication and therapeutic relationships. Our learning objectives for this chapter are to discuss the three different levels of communication, describe the process of communication between the sender and the receiver. We're going to list the characteristics of verbal and nonverbal communication, analyze all the factors that influence the communication process, and describe some of the characteristics of collaborative professional communication, and explain how relationships and roles influence communication. We're also going to describe the role of communication in each of the four phases of the therapeutic relationship, compare and contrast techniques that enhance communication with those that hinder communication, and communicate with clients with impaired hearing and speech cognition and some strategies associated with that, and how to communicate with clients whose culture or language is different than yours. We're also going to talk about how to plan nursing care for a client experiencing some impaired communication. So, what is communication? We know that it is a basic human function that we use on a daily basis, and it basically involves, simply put, sending messages back and forth between two or more people. It consists of verbal and our nonverbal messages that we send, and we use these to help build our working relationships, whether it be with colleagues and peers or our patients. And it helps meet some type of physical, psychosocial, and emotional, and our spiritual needs in some cases. So there are different levels of communication. There are interpersonal communication, which is basically that internal dialogue that sometimes we refer to as self-talk. And that self-talk can either be positive or it can be negative. There's also interpersonal communication, which is a face-to-face conversation between two people. And this is the most frequent form of interpersonal communication. Nurses use this all the time to gather information during our assessment. We use it for teaching folks about health issues, explaining our care, how we're taking care of them, and we also use it to help provide comfort and support to our patients. And then there are group interactions, which basically occur among several people. They can be small or large groups. A small group communication occurs when we engage in the exchange of ideas with two or more individuals at the same time. Some examples of small group communication include staff meetings, committee meetings, educational groups, self-help groups, and family teaching sessions would also fall into this group. And then there's public speaking, which is a very unique form of group communication, and generally the speaker is addressing a group with varying degrees of interaction. Nurses engage in this all the time to educate various size groups about health issues. We also lobby for health legislation in Congress, and we address colleagues at professional conferences as are examples of these. So some of the components of communication involve all of the content of the communication, uh, which it's actually talking about the subject matter. It can be the words, the gestures, and the substance of the actual message. And hopefully this is the message that everyone can hear and or see. Some of the other components of the communication process include the sender. So the sender begins the conversation to deliver a message to another person, and then the sender sometimes is referred to as the source or the encoder of the message. And we use verbal and nonverbal methods to transmit the message. Encoding refers to the process of selecting the words, the gestures, and the tone of voice, the signs and symbols used to transmit that message between the sender and the receiver. The message is the verbal and or nonverbal information the sender communicates to the receiver. It might be a conversation, it could be a speech, it could be a gesture, a letter, and so forth. Effective messages are complete, they're clear, concise, they're organized, they're timely, and expressed in a manner that the receiver can understand. And the message has to be appropriate uh, for the situation and for the developmental level of the person receiving the message. The channel is the medium used to send the message, so that can be face-to-face communication is the most commonly used channel. Nurses use a very a lot of different channels, but the other one that we use that's not so much a verbal message is also the use of touch, where we touch folks and we convey to them that we are caring and concerned about them. And other channels that nurses use, we use pamphlets, written pamphlets. We use audiovisual aids, recordings, telephone calls, text messages, and the internet. And the internet has become a very uh, big part of communication, which has taken away quite a bit from the typical face-to-face interaction that has typically been used most often. Social media is another one that is on, like Facebook and Twitter and Snapchat, and some of these other ones are large channels of communication that are pretty common to most folks nowadays. The receiver is the person who's receiving the message, the listener, if you will, and they're interpreting that message. Interpretation is oftentimes also referred to as decoding, which refers to relating the message to your past experiences to help you determine the sender's meaning. The receiver uses visual, auditory, and tactile senses as well to decode the message. Feedback validates that the receiver received the message and understood it as the sender intended. Feedback can be verbal, nonverbal, or both. And us verifying that message avoids confusion. So, seeking feedback is a very important part of communication. This is just a picture that kind of shows that communication is closed looped, meaning that the sender sends a message over to the receiver interprets that message, and then sends feedback back to the sender. And in all of this, our interpersonal factors affect how that message is sent and how it is encoded and what kind of feedback we give one another. But closing the loop on communication is very important. So, verbal communication is the use of spoken and written words to send a message. And it's influenced by such factors as educational background, our cultures, our language, our ages, and our past experiences really affect how we interpret messages and how we send them as well. Verbal communication is generally a conscious act in which the sender is able to select what we hope is the most effective words to communicate a message. When delivering a verbal message, the goal is that the receiver will understand both your words and our meanings. So, some factors affecting verbal communication are our vocabulary. Some individuals have a very large vocabulary and some not. So, it's our responsibility to deliver that message to the receiver in a way in which they understand. For nurses, the biggest barrier sometimes is our use of medical terms. So we should only be using those when we're certain that the patient is able to understand them. So when encoding a message, we have to consider the receiver's age, their knowledge level, their education, and any cultural differences that we think might affect our messages. And this would also include their primary language. So we want to encourage feedback to be sure that they're receiving and understanding the messages as we intended to send them. So there's denotative and connotative meaning. Denotation is basically the literal or the dictionary meaning of the word. And that is in contrast to the connotation, which is the implied or emotional meaning of the word in the context in which it's being used. The pacing of the conversation, so the pace and the rhythm of the delivery can alter our interpretation of messages. Intonation is our tone of voice, which reflects feelings behind the words. We oftentimes get a sense of a person's tone by listening to the pitch, whether it's high or low, and the cadence, how fast it is. Is it rising and falling? And the pitch will rise and fall. And the volume, is it loud or soft? Clarity and brevity, you can achieve brevity by using the fewest words possible. A conversation that is clear and brief typically will hold the interest of all the parties most effectively, and it also helps convey the intended message a little bit better. Our timing is also important. Timing means that the interaction must allow time for a response. So someone who just constantly talks and talks and talks and then doesn't stop and allow for to ask questions or for feedback. So a rapid flow of questions or one-sided conversations can inhibit our interaction. The relevance of the information. Communication is effective when both the parties value the interaction and find the discussion relevant to what they're talking about. The credibility of the sender depends on a pattern of honest and timely responses to the patient's concerns, as well as a congruence between your verbal and nonverbal communication. So that oftentimes is referred to as sending mixed messages. They say one thing, but their body language is saying another. Humor and laughing can definitely have a very positive effect on our attitudes and the patient's healing. Laughter can create a physiological change that they have shown research that contributes to well-being and provides an emotional release in a tense situation. However, saying that, humor can also be used inappropriately. So, as nurses, we have to make sure that the timing of the humor is appropriate with the patient's situation. So, in this picture right here, if you can look here, you can see that the nurse appears to be upbeat and smiling and full of laughter when the patient appears to be crying and very sad and withdrawn. So this might not be an appropriate use of humor in that particular situation because it's contradicting the entire patient situation that's going on here. So those things that can affect the nonverbal communication, which we just kind of went through, are things like our facial expressions can communicate joy, anger, when we're sad, if we're concerned, if we're anxious, if we're experiencing fear, and those sorts of things you can pay attention to, like raised eyebrows and squinting and darting eyes, all convey certain meanings that can be interpreted differently. Our posture and our gait, if you look at that previous picture, their body position and their posture kind of shows clues to that person's attitudes at that time, as well as their emotions, their physical well-being, and their own self-concept as well. Personal appearance can also enter into that. They can provide clues to a person's feelings, as well as their socioeconomic status, their culture, and their religion. So dress and accessories are powerful cultural clues that we need to clue into when approaching a patient and before we begin our dialogue. And also considering the context of the situation that the patient is in should also be taken into account. Gestures, there's a lot of different kind of hand gestures, and some of us all know what those are. Their hand and body gestures, they can emphasize or clarify the spoken word actually and enhance the situation. But there's always a flip side of that where can also have negative connotation, and those can hinder our conversation and them receiving the message appropriately. So those are oftentimes indicators of our feelings, and the tone behind our conversation can be uh, reiterated and supported by gestures. But those can also be done as well, overdone as well. Touch can convey affection, our caring, concern, and our encouragement to the patient. However, we have to avoid touching when dealing with someone who is angry or mentally disturbed, because that touch can also be misinterpreted. For an example, those can also be in touch can also be perceived as a sign of aggression or sexual attraction. So we have to be very careful when our touch is used. Although touch can be highly effective, like I just said, we have to make sure that we use it with a conscious awareness of the patient's situation, our environment, their culture, and the receptivity of the patient. If they may not be a touchy feely person, then in that case, you have to get kind of good at reading what the patient is going through and how you're going to approach that situation. So if you compare this picture to the previous one that I showed you, you can see that this appears to be a little bit more congruent with the situation. He appears to be happy, upbeat, and she is basically showing him that she is caring by her open posture and her touching him. And you can see that she has kind of um, an expression on her face that really doesn't show any sadness or anger or happiness, but more so that she's being receptive to the patient's feeling and their situation and whatever conversation that they're having. Here's another one that just shows again, touch is important, and touch can oftentimes be a very positive experience for the patient. And sometimes just touching them and maybe not saying anything can oftentimes open the door to that line of communication and that trust and developing that therapeutic relationship with the patient. So there are a lot of factors that we just talked about that can affect communication. The environment, our developmental variations, their gender, personal space, which we all have, and in some instances, that personal space is usually around 3 feet. So anywhere within 3 feet, you're kind of getting into their personal space, and not everyone is welcoming to that. They can also be very territorial of that space, so we have to respect that. There are social cultural factors that affect our communication, and our different roles and relationships that we have with the patient. So when we talk about collaborative professional communication, there is an assertive style that we typically use, and we also use standardized communication tools and a taxonomy, which is basically a standard framework for our communication. So nurses, we have our own taxonomy, and medical professionals have their own taxonomy as well. When I say medical professionals, that would include, I was thinking more of along the lines of doctors have their own language and patients have their own language as well. So all those things need to be taken into account and be considered when we're communicating. So you hear people say, well, they're passive aggressive. Well, a passive approach basically uh, is an approach that we use to avoid conflict and allows kind of the other person to take the lead and run the show. And it tends to be more submissive, um, and it kind of shows sometimes helplessness or maybe they're indecisive or they're apologetic. So all of those, it's a different approach versus an aggressive approach, which is in contrast to that, where it forces others to lose and they're usually overbearing. And the goal is to win the conversation. Aggressive communication can be interpreted as being bossy or arrogant, opinionated, sarcastic, manipulative, intolerant, or overbearing. And I would say a mixture of those sometimes is what we use for communication. So it's sometimes not good to be passive aggressive, and in our profession, oftentimes we have to use more of an assertive approach to our communication versus being passive. So, just to reiterate on that, that the assertive communication that I talked about before is probably the more useful one, where the expression is of a wide range of both positive and negative thoughts and feelings in a way that is pretty direct. Try to be open and honest and spontaneous, and non-judgmental with our communication. Assertiveness recognizes your rights while still respecting the rights of others, and it allows you to take responsibility for your own thoughts and actions without blaming others. It encourages feedback, and it enables you to find mutual satisfying solutions to a conflict by confronting people constructively. Assertive communication has a lot of different characteristics, but in general, we speak clearly and firmly and in a positive manner. We always try to convey a can do attitude. We maintain our professional composure. We question care decisions openly and honestly. Use the I statements so that you take ownership of that. The other thing I typically use is we, which also says that we are in this together and it is a team sport. And try to stay focused on the issue and not so much the participants or their personal attributes. It's also important that we effectively use nonverbal language as well. Try not to invite negative responses to our conversation. We also have to learn to accept criticism without being anxious or defensive, and strive for a workable compromise between each other. That whole combination of using the assertive communication is the one that is most receptive oftentimes versus someone who is very aggressive. In the beginning of this, we talked about some communication tools. One of the uh, frameworks that we oftentimes use is called SBAR, which refers to us describing the situation, the background of the situation, our assessment of that situation and or the patient, and what are our recommendations for the situation. What do we want done? And at the end of that, it's always great to ask questions like, are there any questions? And that provides that two-way communication between two people and allows for clarification of anything that might be confusing to the receiver. Patient rounds is another thing that is used in a big way, and that is basically a more of a collaborative approach in which physician and nurse gather at the patient's bedside to talk about their goals, their plan of care, any changes in the plan of care, and it also allows for them to answer the questions of the patient and the family if they're there. And meeting for rounds allows for the nurse to provide input as well in the process, which has shown to result in improved nurse and physician working relationships and our professional satisfaction. I would also submit that this also increases and more patient positive outcomes, which is why this has all been implemented. They've shown that over 65, or around 60 to 70% of all adverse patient reactions and patient outcomes are a result of poor communication. So some of these have been implemented to hopefully increase the communication and increase positive patient outcomes. So therapeutic communication, you hear that term used a lot, and that is the client-centered communication that's directed at achieving client goals. It's used to establish a therapeutic relationship, provide and obtain healthcare information, and we also use this to express interest and concern for the client and the family. As we're developing a therapeutic relationship with the patient, there are stages. Stage one is basically the pre interaction phase, and this phase involves the gathering information about your patient, um, but the nurse and the client have not had any direct communication with one another at this point. This An example of that would be before you meet your patient, you're going through the patient's chart and reading about what their care is, what their diagnosis is, what medications they're on, and maybe their problem list. And then the orientation phase is basically to establish the rapport and the trust um, with that patient, and that can be achieved both verbally and non-verbally. Uh, the orientation begins with the introduction, followed by an initial exchange of information, such as the client's reason for the visit or the chief concerns. And the orientation phase ends when the relationship has finally been defined. Basically, you come in, you introduce yourself, you say, "My name's Brad, I'm going to be taking care of you today. And for the record, can you please state your full name and date of birth?" You want to know about their allergies. And then you ask them some general questions about how are you feeling? Do you know why you're in the hospital? What's your understanding of what's going on today? And just going through that initial introduction between the two of you. And at the same time, you're establishing a therapeutic relationship, knowing what your role is to them and what they are going to help you achieve. Stage three is the actual where the rubber meets the road, is the way I like to think about that. The working phase is when the nurses communicate the plan of care. They communicate to the patient that we care about them and we're here to take care of them. And we encourage them to express their thoughts and feelings. And there is a show of mutual respect that is maintained throughout this whole thing. And it's important during this phase to be very honest um, with your communication. And the overall goal is to assist the client to clarify their feelings and concerns about their care so that we can get them on board with what we want to accomplish for the day and what we want to accomplish for their care. And after we have the therapeutic relationship established, we have to terminate at some point, whether this be at discharge or it may be them leaving from one unit to another, or maybe to another facility, or maybe they're being transferred to another clinical service. All those could be where we are kind of ending the relationship with them. That could also be viewed as like at the end of the shift when you say, um, you let them know that your shift is ending and that nurse so and so is going to be taking care of you. That would be also a view of termination of the termination phase. But then when you come in the next day again, you might not have to go through all those phases. You might be able to go right into the uh, working phase of the relationship. Some key characteristics of therapeutic communication, and nurses typically do this very well. Being able to show your patient empathy, which is basically the being able to put yourself in their shoes and understand and be sensitive to all of their feelings and their beliefs and the situation. Empathy is more than sharing of information. Empathy requires you to be willing to adapt your style, your tone, your vocabulary, and your behavior to create the best approach for each client situation. Respect, there should be mutual respect between yourself and the patient. And in a therapeutic relationship, we communicate this respect by valuing the client and trying to be as flexible as we can to meet the client's needs. As a nurse, we have to be willing to adjust to your client rather than expecting the client to adjust to you. So the healthcare environment and the hospital routines, all those are very familiar to most of us. We just have to make sure that the client understands that we are here for them and it's not about us. So we have to oftentimes adjust to what the client needs. And I think being very genuine with your communication, people can tell when you're being fakey. So we want to try to respond as honestly as we can. And if you are unable to answer a client's question, don't try to guess. Just be honest and tell the client that I don't have the answer to that. That's a great question, but let me do some research and I'll get back to you. If you do something similar to that, please make sure that you go back and close the loop and go back to that patient and let them know what you found out. I think Genuineness also involves our willingness to do some internal evaluation and self-evaluate. You ask yourself, did I communicate okay? Did I handle this situation appropriately? And if there is any, how can I improve my communication? Concreteness is a reciprocal process. If our client is unable to express their thoughts clearly, we kind of have to be willing to confront them about that uh, request for clarification. Similarly, we must be willing to be confronted if you're unclear. So, most of these things, as you can see, are clearly a two-way street. Confrontation uh, is our ability to, I use it to like call somebody out. So if something's not matching up, I should be assertive enough to ask them, what do you mean by that? Or you're saying this and that, and these two things are not matching up to me. And just that clarification so that you make sure that your perception of what of the situation or your assessment findings or what they told you is accurate. Group communication, we talked about that briefly. Uh, there's task groups that are formed to address or fulfill a need, a specific need. Typically, those members are chosen based on the ability to complete a task. Other times, members are selected for reasons of convenience, such as availability. Maybe they have a vested interest in it or an agenda, rather than for the skills needed to accomplish the goal of the group. Ongoing groups address recurrent issues. Committees are a form of ongoing task groups. So, and they continue to uh, focus on oftentimes quality improvement. It could be infection control, discharge planning, and these members have designated roles within the group. A leader or chairperson is usually the person that's appointed to or elected to head the group. And in larger groups, the pattern of communication form. Some members voice their opinion regularly, whereas others are oftentimes silent. So, when not all members speak, it is essential to examine nonverbal behavior to determine whether the non speaking members are in agreement or not. There are self help groups that are typically voluntary organizations that are composed of individuals with a common need. Members are encouraged to share experiences and seek support from other members of the group. And there are therapy groups that are organized to help individual members cope with challenging personal issues or stressful life events, such as a divorce or death of a spouse, or maybe becoming a new mother. Therapy groups can also address ways to improve relationships and communication, and that's also called self awareness or growth groups. They may be ongoing or have just a small designated length of time. And there are work related social support groups that help members of professions cope with the stresses associated with our work. So, as we're going through here, a focused assessment, we should be able to identify factors that alter a patient's ability to receive and understand and transmit our verbal and nonverbal messages. And some of the things that can affect that are what medications they're on, what's their language, what's their vocabulary, what's their literacy level, what's their cognitive function, do they have hearing disabilities or vision disabilities, do they have aphasia, or are there any psychosocial barriers that we need to be aware of, and what's their overall communication style. So we should be assessing those, and those will help us determine what types of communication and how we're going to communicate with these patients based on what we find in our assessment of these. So for communication can be a problem, and oftentimes it can be the actual etiology of a nursing diagnosis. So the following NANDA diagnosis labels describe communication problems, but note that communication problems may involve the inability to receive, interpret, or express spoken or written words, and our nonverbal messages as well. So we have readiness for enhanced communication, which is typically appropriate when the client expresses a willingness to improve communication that is already effective. So basically, just become better at what they are doing. Impaired verbal communication. This is useful if the client has, let's say, expressive aphasia or physiological problems such as dyspnea. Maybe they stutter, or laryngeal cancer that impairs their ability to speak. This can also be receptive aphasia or sensory deficits that impair the ability to receive messages. And then impaired communication is the preferred diagnosis if a client is unfamiliar with a dominant language or has some other difficulty receiving and sending messages. Note that this is not a NANDA 1 label. So here are some things that enhance our therapeutic communication as we go along. We need to make sure and address the patient. We have to listen actively, uh, establish that trust between yourself and the patient, be assertive when it's appropriate, and make sure that we restate and clarify and validate our messages just simply by asking them, do you understand what I've said? Or is there anything that I can clear up for you? Or do you have any questions? And while we're doing that, we need to kind of keep our eyes open and interpret the body language and share those observations with your patient if you see them. It's important oftentimes where a patient will mention something to us and maybe we're not 100% sure what that means. It's important for us to do what I call a deep dive and slowly begin to explore that issue and find out exactly what's going on and what is the cause of these feelings or the cause of what the patient is telling you. Using silence, it can be very powerful. Sometimes we don't really have to say anything. We can just listen actively and be quiet and try to figure out what's going on. Sometimes a conversation might not be going well, and sometimes it's good just to sit down, maybe next to the patient, and just be quiet for a second. Maybe that using touch would be important then if you feel that it's appropriate. When we get done talking to a patient, it's good for us to summarize what went on in the conversation to make sure that we kind of get to the bottom of what that conversation detailed and what is there anything in there that we need to clarify with them and or the patient. So these are some things that are also barriers to the therapy communication that I've just been talking about. Asking too many questions at one time can be a problem. Uh, a thing called fire hosing information is when you just bombard them with a bunch of information, and it is also important for us to ask why at some point. But there are times when asking why causes some frustration because perhaps the patient can't put their finger on the reason for that. So saying why do you feel like that? Why is this happening? Sometimes that can be frustrating because they may not have the answer. Changing the subject inappropriately. So if you're in the middle of a conversation and something doesn't feel right, doesn't feel appropriate, and you all of a sudden start talking about the weather or the color of the paint on the walls, if you do that inappropriately, that can really affect therapeutic communication. Also, failing to probe what is going on with the patient can be a negative thing because then the patient doesn't know if you really care or not. We are problem solvers by nature, and oftentimes we want to solve problems. So we are typically pretty good at going in and doing what I call a deep six or a little bit of a probe, finding out what's going on with that patient. And we're not in the profession of judging, so expressing approval or disapproval of those feelings or what the patient is saying, being judgmental can have a negative effect on our therapeutic communication. Offering advice based from a personal standpoint can be a double-edged sword. So oftentimes offering your personal advice is not a good idea, and that is different than providing patient teaching. So you got to kind of keep those separate. We want to provide them with optimism, but that is different than providing false reassurance and providing them with untrue statements about maybe their prognosis or about when they're going to get discharged. So you don't want to provide false reassurance in the way that's not realistic. In communication, we talk about stereotyping and generalizations, which are very dangerous because we are lumping a group of people together and then making some assumptions based on that group. And the individual is an individual, and it's hard to use a broad paintbrush with a person and by throwing them into a group and then reacting to situations based on that. That can be dangerous. And they mention here using patronizing language is not a good idea either. So, in general, communicating with clients from another cultural group, as we've mentioned, can be uh, pretty challenging. Just some general guidelines that we can be aware of is to be aware of our own cultural beliefs and attitudes as and that is probably the most important is being able to be aware of what our cultural beliefs and attitudes are and how that's going to affect in our care with patients from other cultures who do not share those beliefs. So when we can, we want to learn about those other cultures, especially in our area. We want to make sure, no matter who it is and what culture they're from, that have the ability to convey the empathy and just show the utmost respect that you can. Be certain that the communication strategies that we're using are culturally appropriate for the individual. We've mentioned touch, so some cultures, uh, touch is not their thing, so we have to make sure that we use that touch very cautiously because in many cultures it's inappropriate to touch, and not only to touch, but to touch certain parts of the body as well. So proceed slowly. Rushing into a situation can cause the patient to be more anxious and is offensive to some. Smile and be polite, but not over friendly or too casual. Make sure you establish a professional relationship with them. Use the patient's title, their first name and their last name when introducing ourselves, and you don't say, hey, you. Uh, those things just oftentimes cause mixed emotions in some people. Use short words and sentences where it's appropriate. Try not to give too much information all in one sentence. So present one idea at a time. And to augment that, providing written teaching materials is also helpful, especially if it's in their language. If there is a language barrier, like I said, the written information hopefully would be provided in an appropriate way to the population that's served and the language of the patient. When in doubt, if I have any questions about a culture, you can always Google it. I guess, but again, there are attaches and there's trained medical interpreters or translators, if you will, and sometimes they're often very educated on the different types of cultural beliefs. So this concludes the lecture on therapeutic communication. There will be another lecture that is going to involve teaching and learning and how to establish that.